Now we know the pathophysiology of burns. But how will we go about the burns? When the patient, generally the burns patients comes to the casualty as an emergency if there is a significant amount of burns. So like any emergency trauma, we have to approach burns. First airway, breathing, circulation, disability, exposure with environmental control and fluid resuscitation. That is how we go about burns in an emergency setting. But how will we know whether the patient is going to be bad or whether the patient is going will recover? The major determinants of burns are the percentage area, surface area involved, the depth of the burns, and the presence of inhalational injury. When to admit the patient? How will we decide on the admission of the patient? Suppose the genitalia, thick skin like palms and soles, and the face is involved. If face is involved, that means there is a higher chance of inhalational injury. All these are indications for admission of burns. Next is if greater than 10% total body surface area is involved. If that more than 10% of total body surface area involved, the patient will generally require fluid resuscitation. And inhalational injury. If there is clear-cut evidence of inhalational injury, it is also a reason for admission. These are the indications regarding the wound. There are other indications also, like extremes of age. If it is a newborn or an old age, there is higher chance for hemodynamic instability. So that it is better to admit those patients. In psychiatric patients or when there is a no proper bystander, the patient will not be able to take care of himself. Then those patients are indications for admission. The non-thermal burn injury like electrical burns or chemical burns, there is higher chance for metabolic poisoning or cardiac arrhythmia. It is better to admit those patients. Then medico-legal injuries. If you see a burn injury like this with the cigarette butt, that is there is a high chance for child abuse. In those cases, it is better to admit those patients and medico-legally evaluate the patient and make sure that the patient is going into for a safe scenario. Now, where to admit the patients? Most of the hospitals will have an admission for the ward for burn patients and ulcer patients, and all those patients may be together. If the hospital is better off, there can be a specialized ward for admission of burns. But most of the patient on burns require admission to ICU if there is a significant amount of burns. But you know, the surgical ICU is a clean unit. Everything is clean and clear. We don't like to bring the burnt patients with who can be infected with regular dressing changes and all those. It appears burns patients in a surgical ICU will be dirty. So most of the surgeons will not prefer to admit the burns patient into their surgical ICU. So in those cases, it will be filthy. So in those cases, for burn patients, we have to have a burns unit, which is a specialized unit because the care for the burn patient is more than those required in a general surgery ICU. So a specialized burns unit with anesthesia support and plastic surgery support should be there to treat a severe burns. Otherwise, if there is no burns unit in the hospital, most of the patients with more than 50% burns, especially if they are deep burns, is going to die. So only when there is a burns unit, we can admit and salvage a burns patient with a significant amount of deeper burns. This is the once we admit the patient, once we have given the emergency care. How do we go about let us understand the different components of the pathophysiology of burns and tackle each of them. So first comes the inhalational burns. In inhalational burns, we know the different components of the burns. In upper airway injury, when due to the hot air gases, there will be change in voice, stridor, and respiratory difficulties. So these are the features we will identify. But mind you, once these features are developed, these are late symptoms. So as soon as you identify this, decide on early intubation and if necessary, a tracheostomy. So when there is change in voice or stridor or respiratory, it is already late. So treat immediately. Don't wait for acidosis to occur. Now, other injuries are deep burns in the trachea with a steam or a chemical pneumonitis. In those cases, depend on history and early signs. Do get a chest X-ray and ABG, and the treatment is by physiotherapy, nebulization, warm humidified oxygen, and with ventilation with continuous or intermittent positive airway pressure ventilation. Coming to the metabolic poisoning with carbon monoxide. Carbon monoxide has more affinity to hemoglobin than oxygen. So again, depend upon the history and early signs like burns in a closed room. If ABG more than 10 in ABG, if there is 10% more than 10% metabolic acidosis, it is significant noise poisoning. Give a high inspired oxygen, and if high inspired oxygen is the treatment. Suppose it is a mechanical block due to an eschar like that. There will be carbon dioxide because it's due to the inadequate ventilation. There will be carbon dioxide retention and there will be increased ventilation pressures. In that case, we have to cut those bands. So, escharotomy has to be done. Now, coming to the circulatory management of circulatory shock in burns. How will we know that the patient has a circulatory shock? We have already said that if there is more than 15% burns, there will be more than 10 to 15% burns, there will be some amount of circulatory shock. If it is 25%, more than 25%, there will be a significant amount of circulatory shock. So the fluid resuscitation of burns will depend upon the percentage area of burns involved. So how will we calculate the percentage? In adult patients, we have the Wallace rule of 9. So all the following are 9 percentages. So head and neck, it is 9%, 1. Then in the upper part of chest, again anterior chest, again 9%. Abdomen, anterior abdomen, 9%. In the posterior back 9% upper part. Lower back, again 9%. Then legs like this. It is so you can either calculate like one like this. Here one leg is 18%, other leg is 18%. But practically when we see the patient, it is better easy to calculate like this. Think of the patient as a board. You will look on either side with 2 hands and head hanging. If you think like that, it is easy. So anterior aspect of legs, it is again 9%. Posterior aspect of leg 9%. Anterior aspect of the lower leg it is 9%, and the posterior aspect of lower leg is 9%. Then each arm 9%. So we have total of, if you see, we have total of 1, 2, 3, 4, 5, 6, 7, 8, 9. One arm it is 10. Next arm it is 11. So there are 11 net. 11 into 9 is 99%. Plus 1% is the genitalia. Plus 1% is the genitalia. So that is a total 100% of the total body surface area. Now what happens when in case of a child? How will we calculate the percentage of burns in a child? You see, when the child grows, its shape changes and the body proportions changes. In a smaller child, it is a large head, smaller torso, and a smaller, large head and a smaller legs. But as the child grows, you see that the head becomes comparatively smaller. The percentage area of head becomes comparatively smaller, and the percentage area of the legs becomes comparatively larger. So it changes with the age. So for the calculation of burns in the child, we have the Lund-Browder chart. We have the Lund-Browder chart. In Lund-Browder chart, you can see the different age groups here. Say in a 15-year-old child, half of the head is 4.5% of 4.5% of the total body surface area. That is, of the total head, it is 9%. Whereas in a 1-year-old, in a newborn child, half of the head is 9.5%. That means in the total head and neck, it will be around 19%. It includes around 19% of the burns. So this is the way we use the Lund-Browder chart and calculate the percentage of burns in different age groups. So if you are in a pediatric surgery casualty, always download and keep a Lund-Browder chart and assess the burns, pediatric burns accordingly. Now, the palm of the adult is around 1%, whereas the palm of the child is around 2.5%. So, we can also calculate the burns with the palm of the patient. Don't do it for the entire body. Use the Lund-Browder chart and the Wallace rule of nines accordingly. Now, burns is not only temperature dependent, but also it is time dependent. More amount of time, more is the amount of burns. So we have, when we take the history, we have to also ask the aspect of time. More the time, more the percentage area of the burns, and more is the depth of the burns. So we should learn about the depth of the burns. In first degree burns, why should we learn about the depth of the burns? Because the further management, after the initial resuscitation, the further management of the burns will depend upon the depth of the burns. In first degree burns, it is only in the burns is restricted to the epidermis. In superficial partial thickness burns, it goes into the papillary dermis. In second degree burns, it is a deep partial thickness burns. It will go into the reticular dermis. In full thickness burns, it will go up to the subcutaneous tissue. Entire dermis is involved. And in fourth degree burns, that is full thickness, again it is a full thickness burns, but again the muscle and the bones can also be involved in fourth degree burns. So for the involvement of skin, it is superficial burns, superficial partial thickness burns, deep partial thickness burns, or a full thickness burns. Now, how will we know whether it is a superficial partial thickness or a deep partial thickness or a full thickness burns? In a superficial burn or a first degree burns, there will be blanching and erythema, and it will be blanching erythema. There will be red in color. Once you press it, there will be blanching, and it will also be painful. Whereas in superficial partial thickness burns, there will be blisters. Again, there will be blanching erythema, but there will be blisters is classical of superficial partial thickness burns. That is this one involving the papillary dermis. Whereas in the deep partial thickness burns, there will be decreased sensation, and because the vessels are involved, it will be yellow or white, and it will be dry and non-blanching. That is the deep partial thickness burns. And the third degree burns is the full thickness burns. It will be white or black or brown, and there can be decreased sensation and non-blanching. Based on this, we can identify which type of burns, what is the depth of the burns. Now, what is the use of identifying these burns? Because if it is a superficial burn, it heals without scarring in 5 to 10 days. If it is a superficial partial thickness burns, it heals without scarring in less than 3 weeks. But suppose there is decreased sensation and it is a deep partial thickness burns, it heals in 3 to 8 weeks, and it will be likely to scar if the healing period is more than 3 weeks. And if it is a full thickness burns, again there will be scarring, and moreover than the scarring, there will be contracture of the limbs. There will be contracture of the limbs happening in full thickness or the third degree burns. So there are different depth of the burns and the clinical implication in healing of the burns. Now, the fluid management of the burns will depend upon the body surface area of the burns. The most commonly used formula is Parkland formula. It is 4 ml into percentage of the body surface area of the burns into weight of the patient. So, first 8 hours, half of this fluid has to be given in the first 8 hours. And the next half has to be given in the next 16 hours. The first 8 hours, we have to calculate from the time of the burns, not from the time when the patient has come to the hospital. We have to calculate it from the time of occurrence of burns, and then the next 16 hours should be calculated accordingly. And by this time, the complete fluid has to be given. This is the Parkland formula. There are other formulas. Other fluids can be given like normal saline or hypertonic saline. Again, colloid resuscitation formulas are also there based on human albumin. But the most commonly used formula is Parkland formula. Now, in case, can we give an oral fluid resuscitation? Yes. If the percentage of burns is less than 10% in children, or if it is less than 15% in adults, oral resuscitation can be considered, especially if it is a superficial burns. Now, whenever we have burns, this is generally we calculate by Parkland formula and give the fluid. But in case of a children, we have to make sure that we also give the maintenance fluid. Especially it is important in children. Adults, it may not make much of a difference because adults it may not make much of a difference, but children will make a significant difference. So we have calculated the deficit by based on Parkland formula. And in children, we have to think about the holiday agar formula: 0 to 10 kg, 100 ml per kg, 11 to 20 kg, 100 ml per 1000 ml plus 50 ml per kg for each kg greater than 10 kg, and for greater than 20 kg, 1500 ml per 20 ml per kg for each kg greater than 20 kg. So suppose it is a 15 kg child, for the first 10 kg it is 100 ml per kg. So it is 1000 ml. And 5 kg, more than 10 to 20 it is 5 kg. Okay, 10 plus 5. So in those 5 it is 50 ml per kg. That is 50 into 50 into 5 is 250 ml. So 1000 ml plus 250 ml. So if it is a 15 kg child, you have to give a 1250 ml of fluid. So that is the maintenance fluid. So in case of a children, make sure that we also add the maintenance fluid for the patient. So how will we know that we have adequately replaced the fluid for this patient? In adults especially, how will we know we have adequately replaced the patient? Is he taking the adequate maintenance fluid orally? We don't know. So to monitor that, you have to make sure that the urine output is 0.5 to 1 ml per kg per hour. Another method is clinical assessment. If the patient is going in for restlessness, tachycardia, or cool periphery, suspect hypotension or inadequate fluids. Next is you can use hemoglobin for the management of fluid. How? Suppose the patient has 12 gram hemoglobin and it is 36% hematocrit. Normal hematocrit should be 3 times the hemoglobin. Okay, 12 into 3 is 36. Suppose the patient is not getting adequate fluid, then the hematocrit will appear like this. There will be 12 gram hemoglobin and it will be 47% hematocrit. This means that the patient is not getting adequate fluid. You need more fluid resuscitation. If it is more than 12 into 3 into hemoglobin, if hematocrit is more than 3 into hemoglobin, it means there is hemoconcentration. Fluid management is inadequate. If it is less than that, it means that we are giving more fluids. So you can use hemoglobin and hematocrit as a guide for the hydration status. Now, next aspect is the constriction rings brought about by the burns. These rings can be in anywhere in the body, in the hands, in the legs, in the torso, everywhere it can happen, and it can cause ischemia of the distal part of it. So how will we manage it? It will be managed by escharotomy. Escharotomy is a bloody affair. So we have to, these are the different escharotomy incisions along the axial planes of the body. These are the different, in thumb it should be like this. These are the escharotomy incisions. So the principles of escharotomy are, they are longitudinal incisions, and those incisions are in the axial planes of the body. We have to incise the escharotomy not on completely through the skin of completely through the scarred skin and into the a bit into the normal skin, and the depth of the escharotomy is down to the subcutaneous fat. Anyway, when we do escharotomy, it is a bloody affair. Make sure that the blood is arranged in the bedside before doing escharotomy, because the patient can go in for bleeding and hypotension. Now coming to the burn wound care. So the different parts, because of the different thickness of the burns and the different evolution of the burns, the burn wound care is different, and dressing has an important aspect in burns. So the principles of dressing of burns are, if it is a full thickness burns or deep dermal burns, those areas will become dead, and those patients will require antibacterial dressings to delay colonization prior to surgery. Suppose it is a superficial burns, they only need simple dressing. So, what if we are not giving proper dressing, the outcome in the borderline depth burns will be different. This is one of high coagulation. This area will be dead. Then there will be a zone of stasis. This is the marginal area, and there will be a zone of hyperemia. This area will generally survive. So suppose we are not giving adequate burn care, this zone of coagulation can extend into the zone of stasis, and there will be more area of zone of coagulation. That means if you are not properly taking care of the burned tissue, the depth of the burns can increase. So in marginally deep burns like superficial partial thickness burns, if we are properly dressing the burns and taking proper burn wound care, it will heal by around 3 weeks. Suppose it gets infected, suppose there is inadequate fluid management, the depth of the burns can increase and it becomes a deep partial thickness burns, which is going to heal by scarring, and it will take more than 3 weeks. Can be associated with contractures if the depth goes further. So that is the importance of dressing in burns. Now coming to the analgesia in burns. This is one of the maybe the most neglected but the most important part in burns. Step 1, we have to give a non-opioid analgesic plus an adjuvant therapy. If there is persistent or increasing pain, then we have to give a weaker opioid plus a non-opioid and other adjuvant therapy like dressing, cooling, like that. And if it is again the pain is persistent, we have to give strong opioids plus a non-opioid and adjuvant therapies. So these are regarding the analgesia of analgesic ladder, which should also be used in the burns patient. Now coming to the nutrition in burns, we have already said that the GIT will be affected, there will be increased edema, there will be ileus, there will be mucosal edema, there will be translocation of microbes. So nutrition of burns may not be taken care completely by the GI system. So additional nutrition in burns patients has to be provided. So there are different formulas to estimate the calories for burns patient, like Harris-Benedict equation, which is a complex equation like this. One of the most handy formula is the Curry formula. It is 25 into weight plus 40 into total body surface area of burns. That much kilocalorie of burns. Or in case of if in ages 60 to 59, if the age is more than 60, it is 20 into weight plus 65 into total body surface area of the burns. That much kilocalories should be given. This is the most widely used formula. But when we calculate the percentage of the burns, don't bother to calculate it by hand. Download an application in the mobile phone and calculate with that application. That is easier. Now that is regarding the energy requirement. Now coming to the protein requirement. Protein needs are higher in case of burns because there will be greater nitrogen losses between 5 to 10 days. So 20% of the kilocalories should be provided by the proteins. And Davis formula is used for the calculation of protein requirement in burns. In children is 3 gram per kg plus 1 gram percentage for the total body surface area of burns. In adults it is 1 gram per kilogram plus 3 gram for a percentage total body surface area of burns. In burns the metabolic rate is high, so we have to supplement the energy and proteins accordingly. In the next part, we will discuss about infection in burns, the role of surgery in burns, how to manage an outpatient burn.